بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أكرم المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. Dear colleagues, we are continuing the series of abdominal imaging, and this is lecture number 11. And in this lecture we will deal with the splenic imaging. And as you all know, the subjects that will be covered in this particular issue will include the normal anatomy, congenital lesions, splenic cysts, infections, trauma, splenosis, sickle cell disease, splenomegaly, portal hypertension, and finally the splenic neoplasms. We all know that the spleen is about 150 grams, and the normal measurements of the spleen are 12 centimeter craniocaudal and 7 centimeter anteroposterior, and 4 centimeter in the thickness. The CT density of the spleen is about 40 to 60 Hounsfield unit, which is less than that of the liver by about 8 Hounsfield units. After the development of multi-detector CTs, we are able to have the triphasic study, and in the arterial phase, you got this mosaic or mottled appearance of the spleen during the arterial phase, and this is considered normal, as you all know. And after or in the portal and the delayed phase, you will see homogeneous enhancement of the spleen. As you can see also in the MRI, in the arterial phase in the dynamic study, you got mottling or mottled appearance of the spleen due to inadequate or inhomogeneous enhancement of the sinusoids. Then in the portal phase and the delayed phase, you got homogeneous enhancement of the spleen, and this is considered normal. The normal spleen will appear of relative low signal in the T1 weighted image, and it will show increased signal in the T2 weighted images, as you can see in this example. Some of the congenital lesions of the spleen include the presence of a small accessory spleen, which is known as the splenule. And the splenule is a small spleen which is located adjacent to the original one. It will show the same density of the splenic tissue in the pre-contrast scans and also in post-contrast scans. As well as in cases of MRI, the splenule will show the same signal intensity similar to the original spleen in all pulse sequences. One of the major informations about this splenule is that after a splenectomy, this splenule may significantly become large to replace the site of the removed spleen. And also this splenule may be mistaken for tumor in the tail of the pancreas and sometimes in the region of the suprarenal gland. This is the appearance of the accessory spleen in MRI T1 weighted image and T2 weighted image. Look that the splenule is similar to the spleen in all pulse sequences, and after contrast injection, this is the arterial phase and this is the portal phase. This is the splenule showing similar appearance to the original spleen. The splenule, as you can see here, there are two splenules, this one and this one, which is intimately related to the pancreatic tail, and in sometimes this splenule may be mistaken for a pancreatic carcinoma. Then sometimes also the accessory spleen may be located inside the pancreatic tissue, and this is an intrapancreatic accessory spleen. In the T1 weighted image, it looks similar to the spleen. In the T2 weighted image, the same, and after contrast enhancement, it shows the similar signal intensity and enhancement to that of the original spleen. You know that the normal splenic position is in the left hypochondrium with the hilum facing medially, but sometimes you get what's known as upside down spleen, where the splenic hilum may face upward, as in this case. And one of the congenital lesions of the spleen is the polysplenia and asplenia syndromes. These are rare congenital anomalies which may be sporadic or familial, and in cases of polysplenia, you got too many spleens at the original site of the spleen itself. And as you can see in this case, this is the site of the spleen, and you got too many soft tissue masses representing multiple spleens. And in this condition, there are two other major almost fixed abnormalities in the patient, which include number one, the abnormal position of the liver, which may be in the middle of the abdomen, what we call situs ambiguous, and the absence of the inferior vena cava, which is replaced by or continued by the hemiazygous vein. Then here also you can see that the stomach is on the right side of the patient. The polysplenia and splenia syndromes are associated with numerous congenital anomalies in the gastrointestinal tract and in the cardiovascular system. In the GIT, there are a lot of lesions, including esophageal and duodenal atresia, tracheoesophageal fistula, annular pancreas, gastric duplication, bowel malrotation, absent gallbladder, and biliary atresia. And these are the cardiovascular associations, including situs ambiguous, where the liver is in the middle of the abdomen, not to the right, not to the left. Acyanotic left to right shunt lesions like ASCD and patent pulmonary arteriovenous drainage. Then this is one of the important findings, continuation of the azygous vein instead of the IVC, transposition of the great vessels, double outlet right ventricle, pulmonary stenosis, and subaortic stenosis. This is the case of polysplenia. You see the multiple spleens which are located now in the right hypochondrium, and the liver is in the middle of the abdomen, and there is no IVC, and there is continuation of the IVC by the hemiazygous vein. And another case of polysplenia syndrome, you see multiple spleens in the right hypochondrium, the liver is in the middle part of the abdomen, and the IVC is absent, and instead there is the azygous vein. Also, the wandering spleen is that the spleen is mobile. It is not located in the left hypochondrium, and instead it is seen lower down in the abdomen. In such cases, this is a common location of the wandering spleen and common appearance as well. The spleen is facing posteriorly, and the hilum of the spleen, instead of facing medially, it faces backward to the posterior abdominal wall. Then we came to the issue of the splenic cysts, and in the spleen we have primary cysts with true epithelial lining, including the congenital simple cyst like that of the liver, the hydatid cyst, and the epidermoid cyst. Secondary splenic cysts with no epithelial lining are usually the sequelae of a previous splenic insult, like splenic trauma or infection or infarction. And in most of the cases, it is usually difficult to differentiate between the primary and the secondary splenic cysts unless you have adequate clinical data and the previous imaging techniques. And here is an example of post-contrast CT scan of the abdomen showing a water-filled lesion in the region of the spleen, representing a splenic cyst. Then a splenic cyst by MRI will show low signal in the T1 and high signal in the T2, and the cysts in the spleen do not usually show contrast enhancement similar to those of the liver. And then the splenic cysts are usually discovered incidentally, and they show the typical criteria of simple cyst. And you remember the typical criteria of a simple cyst anywhere in the body are 7: 3 positive and 4 negative items. The positive items are paper thin wall, sharp, well-defined margin, and clear water or fluid content. The negative findings are no septation, no calcification, no enhancement, no mural nodules. And these are the criteria of the typical benign simple cyst anywhere in the body. Then the complications of the simple cyst are three: either rupture if it is large, or secondary infection, or internal hemorrhage. Then hydatid cyst in the liver is diagnosed by the presence of calcification in the wall of the cyst, and this is the case also in splenic hydatid cysts. Also, you can diagnose hydatid cyst by the presence of floating shadows inside the cyst, or the presence of daughter cysts inside the big cyst. These are the three major criteria for diagnosis of hydatid cyst in the liver or in the spleen. But you should remember that some of the splenic cysts, especially the secondary cysts, may show mural calcification. Then you are not able to differentiate between hydatid cyst and the other cysts based on calcium. But we used to diagnose a cyst like this or a cyst like this as hydatid based on the presence of marginal calcification. But you should put in your mind that some of other cysts in the spleen may show marginal calcification, but calcium usually in favor of hydatid cyst. Then in cases of pancreatitis, there may be invasion of the inflammatory substance, or the inflammatory granulation tissue being adjacent to the spleen may spread inside the spleen, and it will result in multiple cystic lesions inside the spleen, and these are known as splenic pseudocysts of pancreatitis. Of course, in order to diagnose these cysts inside the spleen as related to pancreatitis, there should be signs of pancreatitis in the pancreas, like the swelling of the pancreas, the obliteration of the peripancreatic fat, and the presence of fluid, either free or encysted, like in this case, and this is a pseudopancreatic cyst in a course of acute pancreatitis with extension of the process inside the spleen. Then splenic abscesses are also similar to those of the liver. They are fluid containing lesions, and whenever you inject contrast media, you got marginal enhancement. And sometimes you can detect air inside the lesion, and this is one of the diagnostic criteria to help you for the putting the possibility of an abscess. The marginal enhancement is one of the criteria, and the presence of air inside the lesion, especially whenever this patient is not touched by any of the clinicians who would like to have some samples from this fluid for culture, or even for just analysis. But if you put a needle, you expect to introduce some air. But if you see air without any history of introduction of any needles, then you are almost sure that this is an abscess. Then abscesses may be due to bacteria or other organisms, and the abscesses may be, especially in the spleen, may occur in patients with immune compromised state, and whenever the splenic abscess ruptures, it may lead to peritonitis. And you see here in this post-contrast study, this is the spleen, and this is the a marginally enhanced lesion, fluid containing, in the posterior part of the spleen, representing an abscess. Then we came to this issue whenever you see multiple small cystic lesions in the spleen, or in the spleen and in the liver. And you may think of polycystic disease, for example, but you remember the polycystic disease of the liver, the cysts are large and the contents are of fluid density, and there no marginal enhancement. But if you see multiple small cystic-like structures within the spleen, one of the good diagnostic possibilities is the abscesses, especially of fungal etiology. And the fungal abscesses may represent about 26% of the splenic abscesses. Then this is a good possibility whenever you see these lesions, low signal lesions in the T1 and high signal in the T2. Whenever you inject contrast media, you got marginal enhancement, and you can see this enhancement better by MRI. Then if you know that this is an immune compromised patient like this one in HIV, then a good possibility for the diagnosis is the presence of fungal splenic abscesses. And we'll discuss this issue at the end of this lecture, and under the title of spotted spleen. And here you can see multiple lesions in the spleen. They do not look cystic in this CT scan, but in MRI they look cystic, and they show low signal in the T1 and high signal in the T2. And as I have said, whenever you are sure that these are cystic lesions, one of the best diagnostic possibilities is the fungal abscesses. Then in this particular patient who had an abnormal chest X-ray taken because of long-standing respiratory problems, then subsequently CT scan of the chest and abdomen were performed. This is a slice from the scans of the abdomen showing small lesions scattered in the liver and other lesions in the spleen, and these lesions by CT do not look cystic. The scans of the chest show the presence of interstitial opacities as well as minute nodules, and the mediastinal window shows the presence of slightly enlarged lymph nodes in the prevascular area as well as posterior to the superior vena cava. Then the presence of lymphadenopathy, especially if the lymph nodes are discrete and homogeneous, as well as the presence of interstitial pulmonary opacities, is suggestive of sarcoid. Then sarcoid can also affect the liver and affect the spleen, and this is one of the causes of a spotted spleen, as I will mention. Then if you see multiple lesions in the spleen and the lesions are cystic, one of the best possibilities is fungal abscesses. But if the lesions are solid, then you think of lymphoma, as I will mention, and you think of metastasis, and also do not forget the possibility of sarcoid. Then in order to diagnose the splenic tuberculosis, especially in the healed state, and you will see that the spleen is affected by multiple calcific foci scattered throughout the splenic parenchyma, and this is diagnostic of TB of the spleen. This is one of the cases of calcifications in the spleen, and also a small focus of calcium in the liver, as well as calcification of the mesenteric lymph nodes. And also there are some calcified foci scattered in the lung, and this is TB of the spleen and the liver, mesenteric lymph nodes, as well as the lung. Then we came to the issue of the splenic trauma, and I have explained this in details in the sector of abdominal trauma. And you remember that whenever you see hemorrhage in parallel to the surface of the spleen is intact, and this is diagnostic of subcapsular hematoma. And you remember also that the splenic injuries are intimately related to the number 3, the superficial lacerations and subcapsular hematoma, which is less than 1 centimeter, is indicative of stage 1 injury or grade 1 injury. When the laceration is from 1 to 3 centimeter deep with subcapsular hematoma less than 3 centimeter, this is stage 2. And if the laceration is deep more than 3 centimeter and the subcapsular hematoma is also larger than 3 centimeter, then this is stage 3. And the stage 4 means that there is a fragmentation of the spleen more than 3 pieces. Then this is an example of splenic laceration or shattered spleen. There is laceration and fragmentation of the spleen into multiple pieces surrounded by a large area of hematoma. And this is a grade 1 splenic injury with follow-up of after conservative treatment, and this is the contusion, and this is the healing of the splenic injury. You know that the CT overall accuracy in diagnosis of splenic injuries may reach about 98%, and grade 1 and grade 2 of injuries of the spleen will heal within 4 months, while grade 3 will heal over a 6 months duration, and grade 4 of course is an indication for splenectomy. Then the issue of splenosis is the presence of multiple small spleens scattered throughout the abdomen and the pelvis, and this may occur after splenic trauma or splenic surgery, with rupture of the spleen and dissemination of the splenic tissue into the abdomen, and this splenic tissue will grow by time to form small spleens. And this is the case, and this is known as splenosis, and this diagnosis cannot be obtained unless you know that there is a previous history of splenic trauma or surgery. Then you see this shadow and this one and this one and these two lesions, they represent multiple spleens in the abdomen and pelvis in a case of splenosis after splenectomy. Infarctions of the spleen have many etiologies, including the embolic causes and the thrombotic causes, as well as the sickle cell disease. And the infarction, by definition, is an area of hypodensity devoid of vascular supply, with usually triangular in shape, with base outside and the apex is inside. The splenic infarction may be single and may be multiple and may involve the whole spleen. And you know that the patient with splenomegaly or the enlarged spleen is usually prone or susceptible for the development of multiple infarction. This is the spleen with no evidence of infarctions, and this is the follow-up study showing the development of multiple patchy hypodense non-enhancing subcapsular areas representing splenic infarctions. Then the sickle cell disease has an intimate relation to the spleen, and there are too many complications that can affect the spleen in patients with sickle cell disease, including splenic infarction, splenic sequestration, rupture, hemosiderosis, and autosplenectomy. And the splenic infarction is similar to any infarction, and you see wedge shaped hypodensity with the base outside, apex inside, and reaching the capsule of the spleen. And the splenic sequestration in patients with sickle cell disease means that there is a large amount of blood that has been trapped inside the spleen, leading to splenic sequestration. The spleen is huge and may bleed, leading to sequestration crisis. In this condition, you can see that the spleen is large and the splenic parenchyma is mottled. Some are hyperdense, representing the trapped blood within the spleen, and the rest of the spleen is hypodense, reflecting the ischemia of the splenic tissue itself. And this is the case of splenic sequestration, and this is the the specimen showing the trapped blood within the splenic tissue. In these cases, the patient is known to have sickle cell anemia and presents in acute condition with enlargement of the spleen and mottled appearance, being hyperdense due to trapped blood and hypodense due to ischemic splenic tissue. Then autosplenectomy means that the spleen is small and is densely calcified. And you can see here, this is the spleen which is very small and calcified in a case of sickle cell disease, representing autosplenectomy. And you know that the deposition of iron in the liver and in the spleen may lead to secondary hemochromatosis, and you know this by the marked loss of signal of the liver and the spleen, and they compare this signal by the signal of the muscles. And you know that iron is not deposited in the muscle. If it is in the spleen and in the liver, you compare by the signal intensity of the muscle. Then if you see that the liver is more dark than the muscle, and you know that this is hemosiderosis or hemochromatosis. And in this case, you hardly see the spleen, which is very small, and in a case of sickle cell anemia with autosplenectomy. And here is a case of iron overload affecting the liver and the liver and the spleen, as well as the kidneys in a patient with sickle cell disease. Then splenomegaly, meaning that the spleen is enlarged, and the spleen may be hugely enlarged. Like in this case, there are a lot of reasons for the splenic enlargement, including the cases of portal hypertension and splenic vein thrombosis, infiltrative diseases like Gaucher's and histiocytosis, cysts and tumors, especially in the cases of lymphoma, hematologic disorders like polycythemia vera and myelofibrosis, and some kinds of infection. You know that the craniocaudal diameter of the spleen is 12 centimeter, and in cases of splenomegaly, the spleen may be hugely enlarged, reaching the left iliac fossa. And of course, the craniocaudal diameter is larger than 12 centimeter in diameter. Sometimes in patients with portal hypertension is not in a good percentage. It's about in 9 to 12% of the patients with portal hypertension, you got this appearance of the spleen. The spleen may be enlarged, and the splenic parenchyma will show small dots of persistent low signal in all blood sequences, representing hemosiderin, and this is known as siderotic splenic nodules or Gamna-Gandhi bodies. And this, I have said, are usually seen in patients with portal hypertension, few number of cases of portal hypertension, and this is an example. The lesions are best seen in the gradient images and also in the T1 weighted image. but they are not well appreciated in the T2 weighted image. And this a severe example of siderotic splenic nodules with too many low signal nodules scattered throughout the splenic parenchyma. And this is a case of liver cirrhosis and splenomegaly with multiple siderotic nodules seen in the splenic parenchyma. In cases of portal hypertension, you got the opening of the portal systemic collaterals, which will lead to the formation of esophageal varices and the varices around the umbilicus and also the those in the colon. And I have discussed this issue of the esophageal varices when I discussed the lesions of the esophagus, and I have said that there are an uphill and downhill esophageal varices, and I explained the causes of both types. But in imaging, in patients with portal hypertension, you can see that there are multiple dilated tortuous collateral venous channels around the spleen and at the gastroesophageal junction and also in the abdominal wall. And this is a case of liver cirrhosis and splenomegaly with portal hypertension. And you can see that the portal vein is dilated and there are markedly dilated portosystemic collaterals around the splenic hind. And you remember that in the era before CT and MRI, we used to do this technique, which is known as the splenoportography. We put a needle percutaneously into the spleen and inject a large amount of contrast media, aiming at opacification of the splenic vein and the portal vein, and to show the presence of varices at the gastroesophageal junction or around the stomach. But this invasive technique has been now replaced by the CT portography, where the contrast media is injected intravenously and you scan the abdomen while the contrast media is in the portal system, and you reconstruct the image. You remove undesired structures so that you can see the splenic vein, the portal vein, and the superior mesenteric vein. And this is a good example of CT portography of a patient with cirrhotic liver, splenomegaly, and portal hypertension. You see the portal vein is slightly dilated, and there are some collaterals or portosystemic collaterals at the gastroesophageal junction. And this is the coronal reformatted image of the CT at the thoraco-abdominal junction, and we see extensive dilated collateral venous channels at the gastroesophageal junction, representing a severe case of esophageal varices. Then finally we came to the issue of the splenic tumors, and we have benign lesions and we have primary and secondary malignant tumors. One of the common lesions, benign lesions in the spleen, is the hemangioma. And you remember that the hemangioma is also considered the most common benign primary tumor in the liver, and it is also the case in the spleen. The hemangioma is usually an incidental finding. It can be multiple in this Klippel-Trenaunay syndrome, and the whole spleen may be involved by extensive what we call hemangiomatosis. The hemangioma, whenever it is small, you got immediate total filling with contrast media, what we call flash filling hemangioma. This is a case of liver cirrhosis, and you see the liver is shrunken with ascites, the spleen is enlarged, and an incidental hemangioma. And this is a splenic hemangioma by MRI. In the arterial phase, you cannot see the hemangioma, but later on you see filling of the hemangioma with contrast medium. And this is a hepatic hemangioma and a splenic hemangioma as well. In the liver, you have three hemangiomas. One is very small and medium size and large. And they show the classic appearance of peripheral nodular contrast enhancement. And in the spleen, you have a very small hemangioma in the posterior wall of the spleen. Also, you can see fat-containing lesions in the spleen and in the liver, and this is just the lipoma of the spleen. Then you came to the malignant lesions, and you should know that primary malignant lesions of the spleen are rare, and the splenic metastases are uncommon. The primary lesion is angiosarcoma, and this is the most common non-lymphomatous malignancy. And you know that lymphoma is the most common malignant lesion of the spleen. The diagnosis of angiosarcoma of the spleen cannot be obtained actually, in my opinion, without the biopsy, because there is no specific CT or MRI finding to predict that this is an angiosarcoma. But we used to diagnose solid masses in the spleen as lymphoma until proved otherwise, because lymphoma is far common compared to other solid lesions in the spleen. And other primary splenic malignancies may include angiosarcoma, hemangiopericytoma, lymphosarcoma, and spindle cell sarcoma. And this is an example of a spindle cell sarcoma of the spleen. You got a huge splenic enlargement being infiltrated by a mass with central areas of necrosis and areas of contrast enhancement. This is in the arterial phase, and this is in the delayed phase. Again, splenic deposits, as I have said, are uncommon, and they go to the spleen by the hematogenous spread, and most of the splenic deposits are usually small and may be cystic depending on the primary malignancy. The non-primary malignancies include the breast, the lung, the ovary, the stomach, and melanoma, of course, and the prostate. Calcification is rare and similar to those metastases in the liver coming from the mucinous adenocarcinoma of the colon. And this is a case of bronchogenic carcinoma with multiple splenic deposits as well as huge bilateral adrenal deposits. You know that the adrenal gland is one of the common sites for metastasis of the bronchogenic carcinoma. And this is the splenic metastasis in a patient with a small cell lung cancer, and you see the focal lesion, and after contrast injection in his considering the patient is known to have a primary malignancy and you suspect that this may represent a splenic deposit. Then direct invasion of the spleen by nearby malignancies like those of the stomach and the pancreas may occur, and also implants over the surface of the spleen from the peritoneal metastasis can be also occur beside the hematogenous spread. This is an endometrial carcinoma metastasizing to the spleen and to the liver as well. And we came to the lymphoma, and lymphoma is the most common malignant lesion of the spleen. The spleen is involved by Hodgkin disease in about 27% of the cases, and in cases of non-Hodgkin lymphoma in about 35% of the cases. We have 4 patterns of splenic involvement by lymphoma. Number 1 is enlargement of the spleen with homogeneous CT density, no focal lesions, solitary focal lesion, multiple splenic focal lesions, and a diffuse infiltration. And here is a good example of splenic lymphoma, multiple solid lesions infiltrating the splenic parenchyma. Then enlargement of the spleen without detection of any focal lesions is not diagnostic of lymphoma, but you should confirm this by other clinical and laboratory data. But huge splenic enlargement is one of the manifestations that can be seen in patients with lymphoma. Solitary focal lesion this is the spleen being involved by a big single solitary focal lesion. Multiple focal lesions, which is the most common presentation. You see multiple solid focal parenchymal lesions in the spleen and solid lesions in the spleen. First possibility should be the lymphoma. Then diffuse involvement, you see that the spleen is enlarged, but the parenchyma is not homogeneous. And if you look carefully, and you can see minute hypodense focal lesions scattered throughout the splenic parenchyma, and this means that there is diffuse infiltration of the spleen by lymphoma. And as I have said, splenomegaly is not a reliable indicator of lymphoma, since 30% of patients with lymphoma have normal spleen, and 30% of patients with lymphoma have no splenic involvement. Then this is the case of lymphoma. The spleen is big, but what's more important is the presence of bulky amalgamated mesenteric and retroperitoneal lymph nodes, and this appearance per se is suggestive of lymphoma, and we are not sure about the spleen, if it is infiltrated by lymphoma or not. Then finally we came to the issue of the spotted spleen, and the spotted spleen means that you got the spleen with multiple small hypodense focal lesions, either cystic or solid, and the possibilities are either inflammatory or neoplastic. Inflammatory lesions, you should remember the fungus on top of the possibilities. Then you remember TB, and you should also remember sarcoid as well as parasitic infestation. And tumors, number one is the lymphoma, with the most common metastasis. If there is a non-primary malignancy, hemangioma, especially in the hemangiomatosis type, where you got multiple splenic hemangiomas affecting the spleen. هذا وبالله التوفيق والحمد لله رب العالمين.